Hi, everyone. Welcome to the Superpeeler podcast. My name is Lori, and I'm very excited today to be joined by Dr. Shannon Sauer-Zavala, who is the author of, or one of many authors, I suppose, of a brand new book coming out that I'm really excited to chat with you all about. It's coming out August 1st, so by the time you hear this, you'll be able to grab it. So absolutely excited to have you. You're a professor at the University of Kentucky, and yeah, clinical psychologist. So maybe just tell us a little bit about yourself as a human first. What brings you to this world and this work?
Yeah, absolutely. So I currently, like you said, I'm a clinical psychologist and I'm a professor at the University of Kentucky. In my personal life, I am partnered and I have two daughters. And I think about myself first as a researcher and a treatment development researcher specifically. And I really come to that work from basically from the idea that treatment for any condition and borderline personality disorder, in particular, is really hard to access.
Mm-hmm.
And I could make the most difference in the field, in the world, in helping people if I were developing treatments that were easier to get into the hands of people that need them, right? Not trying to kind of force existing treatments into systems where they maybe don't fit as well, and really think from scratch about how do we get the skills that people need to the people that need them.
Yeah, which is amazing. And if I remember correctly from Googling you, you're also trained in DBT, right?
Yeah,
Dialectical
yeah.
behavior therapy. Yeah. Okay. Yeah. Because when we go kind of into the book a little bit more detail, I was like, there's definitely some BPD like esque lens here, which I love because my life was changed and saved by DBT. But what I love about what you're doing is that it's not just DBT and it's a lot more accessible, I find, to people who either, I again, obviously love Marsha Linehan, saved my life, but not everything she wrote was all that accessible to people. The treatment itself isn't accessible to people, especially if you're trying to do like the full DBT. And then also, there's a lot of people who have tried DBT, said it didn't work for them. And so then they're resistant to doing anything that says DBT, which this doesn't. So I thought there was like a lot of interesting, I don't know if that was strategic or if this is just like because it's brand new. Anyways, yeah.
Yeah, yeah. So I think you're hitting on a lot of points that we as developers thought about when we were kind of packaging this. So there's a lot of things kind of happening in the personality disorder world over the past 10 years that I think really warrant looking at treatment through a different lens.
Mm-hmm.
And so, what I'm talking about is the alternative model of personality disorders, which has been like largely adopted by the World Health Organization with the ICD system. That's kind of the diagnostic system in the rest of the world,
Yeah.
versus the DSM. And essentially, instead of like looking at folks by just like, yes, no, you have a diagnosis, you're getting more information about what might be underlying those symptoms. And specifically for borderline personality disorder, in this alternative model, they suggest that people with this condition may experience elevations in emotional vulnerability, which we know
Mm-hmm.
from like
Yeah.
our DBT model, that they may experience deficits in agreeableness or trust. And that's not really surprising either,
No.
because when you think about the other evidence-based treatments for BPD, like mentalization, like transference focused psychotherapy, that's really what they're targeting, like attachment security, ability to trust in others. And then also that people with BPD may experience like disinhibition, so impulsivity. And I would argue that like the DBT and these like relational treatments, they don't really handle just like I'm an impulsive person outside of the context of like I'm experiencing a strong emotion or I'm like in it with somebody interpersonally. And
Yeah.
so for me, when I was thinking about developing a treatment, I wanted something that was comprehensive. When you look at the treatment outcome studies that compare DBT to the relational treatments head to head, like they are equivalent. Like there's no
Yeah.
difference. It's just that some people don't respond to DBT and some people don't respond to the relational treatments. And what that says to me is that there's a mismatch. Like maybe the relational treatments, people that got that and didn't respond would have, their symptoms are driven by like
Right.
emotional processes. And so I wanted a treatment that was like a little bit more of a choose your own adventure, like figure out what it is that's driving your symptoms. Because a symptom, say like substance use, some people use substances because they don't want to feel things, and that works like a charm for that, right? Some people use substances because they're not thinking about consequences and it feels good. And if you target the like it feels good with the emotion vulnerability side of things, that's not going to fix that.
Yeah.
So I wanted a treatment that like had a little bit more precision there. So that's the first piece. I'll stop there because that's a mouthful.
Yeah, no, I love that you're bringing in like these other models in this dimensional aspect. And if people are listening to this and going like, what on earth is she talking about? Go back to May. We had Dr. Stephen Huprich come on, and he talked all about all of this stuff. So if you're listening to this and going like, I need a refresher, that's the episode. I'll link it in the show notes as well. But I really love just even developing new treatments at all at this point, because I feel like, I obviously I kind of was diagnosed when BPD was still considered untreatable, or largely considered untreatable, which causes challenges obviously. And then now I'm, even reading your book, you're like, it's a highly treatable condition. And like, yeah, it is a highly treatable condition. And like, I've only been in this space for like 13, 14 years now. And like the fact that we're developing things, knowing that it is treatable is just like so validating and so hopeful, I think. And it's also hopeful that we're not just like, oh, well, DBT works, so we're just going to go stick with that. We're like, well, DBT works, but like, what else can we do? Like the whole purpose of this is like, that's not going to work for everyone. It's super freaking expensive. And how can we put different options of healing in the hands of the actual people that need it? And
Yeah,
that's, I think, what
yeah.
you're doing here.
Exactly, right? And so that's the like ingredients in the treatment piece, which is like
Mm-hmm.
kind of informed by, an emotion dysregulation, emotion vulnerability side of things from, what works in relational treatments, and then really pulling from the substance use literature to get some of that disinhibition impulsivity work into the treatment. And I think that's important, right? It's like an accurate treatment in that it's updated with the science.
Mm-hmm.
But I also think like another reason for developing a new treatment is exactly what you're saying, that I think as a field, view BPD through a slightly different lens, or in a dramatically different lens, in that like it is treatable. And when you are, I don't know, it's like in 1993 and you're Marshall Linehan and you're developing a treatment that everyone says is untreatable, you're
Mm-hmm.
like, let me throw everything at it. Like, we need the
Yeah.
big guns here. And that, of course, is going to result in this Cadillac treatment that has coaching calls, that has group, that has individual, that has a million different rules for how therapists are supposed to validate or be irreverent and all of those things. And it works. And that was huge for, I think, changing the narrative for
Mm-hmm.
sure. But I think like there's also been, I don't know, how's the way that I want to describe this? Like, in some ways, like, I think it changes the narrative to treatable, but I think it also, like, sets BPD up as like, but it's super severe. It needs a specialist, and it needs really high intensity treatment. And I think part of that, like when you look at the clients that were recruited to be in those initial DBT studies, they specifically recruited folks that had 2 hospitalizations for suicidality in like the previous 6 months. So we're talking about probably the most severe end of the spectrum. But when you look at epidemiological studies of BPD, it's like most people haven't had a suicidal crisis in the past 5 years, right?
Right. Yeah.
So it might not be warranted for everybody. And so that's a space that I really wanted to come into. I wanted a shorter term treatment that was just like easier for patients to do.
Mm-hmm.
But I also really wanted, so part of the reason there's a workbook versus just like therapists get trained and kind of come in with the worksheets, a workbook is because I really wanted to model it after like the panic disorder treatment, or like the GAD treatment, or the social anxiety treatment, where the therapist, generalist clinician, could just go on Amazon and order the book and be like, let me leaf through this. Okay, I could do this. Really opening up a wider array of people who could help folks.
Yeah, I think that's amazing. Even this, just on the severity piece, like it's even if you have the severity and we have a treatment for it, if you can't access it, then there's no point, right? So like whatever you can access is the best that we can do at the moment. And like obviously there's systemic changes that need to happen to be able to get better access. But until that's the case, we can't just say, oh, but we have a great treatment if nobody's accessing it, or very few people.
Right. Or only like wealthy people that don't.
Or wealthy, exactly, totally. Wealthy people are very, very, very ill people. And it's like, well, we want people to get to treatment long before they get to the very, very, very ill, right?
Yeah.
So BPD Compass. I love the name. First of all, this is the workbook and the treatment, and I also wanted to acknowledge that I love the title of it, because I'm finding there's been a shift recently in literature about BPD to arguably I'm at fault because my podcast is called Super Feeler. It doesn't have the word borderline in the title, but I do think that there's a shift away from putting BPD on the cover of a book, because people are afraid that that's going to limit the scope and that it's going to make people afraid to buy it. And I get that logic, but for people like me who are seeking out BPD resources, I also may not see what I need. So I'll just, if for those of you who are watching the video version, this is I have the digital version, but the BPD Compass workbook. So do you want to tell us maybe how this really came to be? The treatment itself. And what does the treatment look like? Is it just the workbook being used with a generalist clinician?
Yeah. So, okay. So I can answer the first question, like, how did it come to be? So, you mentioned at the beginning, I am trained in DBT. Being a DBT group leader was the very first clinical experience I had as a second-year graduate student. Like, I went into graduate school knowing that I wanted to do this, saw individual clients and took coaching calls through like my entire training, went to a DBT focused internship, and I actually interviewed with Marsha Linehan for a postdoc.
Oh, wow.
I know. Yeah. So like, we're talking like,
you're in.
All in.
You're as culty about DBT as I am. Yeah.
Yeah. So all in. And at the same time that I was applying for postdocs, I had also applied to work with David Barlow at Boston University. And at that time, he was developing a treatment called the Unified Protocol. And that is a treatment for basically emotional vulnerability. It was a workbook, a transdiagnostic treatment that was developed to more efficiently target like all anxiety disorders, depression, eating disorders, anything that sort of results from experiencing strong emotions, not liking them very much, and engaging in efforts to push them away. Because that's what people with all of those disorders do. If it's panic disorder, you leave the movie theater. If it's, if it's an eating disorder, maybe you binge or you restrict, right? It's all about managing those negative emotions. And my mentor at the time, my supervisor on internship, was like, Shannon, you could be the person that could bring the UP to borderline personality disorder. And I was like, not gonna lie, I like the sound of that. That sounds cool. Yeah. As like how old was I at the time? I don't know, like 28, and was like, I want to do that.
Yeah, you're like, I can change the world. Yeah.
Yeah. So I ended up accepting that position and learned all about this like manualized short-term treatment, like originally designed for anxiety disorders, but my first study that I led there was adapting it for BPD. And I was like all in on this, like BPD is driven by emotional vulnerability. This is going to be the treatment. We're going to do it in 20 weeks. And I had, I did a case series. I had maybe 6 patients, and I would say like 4 of them responded really well. We saw great improvements in 20 weeks. And then the other few patients like either didn't get better or like actually got worse. And I was just like, what the hell? Yeah. This is not how this is supposed to go. This is not what I thought was going to happen. And when I put on my sort of like clinical scientist hat, where you sort of look at you're really trying to evaluate what's happening here. When I looked at the characteristics of people that didn't respond, like the 2 people that didn't respond, one was like really not taking responsibility and was really like blaming other people and how other people treated them. And so there was that piece. And then there was like the other person was just like really, really impulsive. Like wasn't even thinking about skill. It was just
totally.
And That was, I want to say like 2013, which is that's the year that DSM-5 came out and the alternative
Right,
model
yeah.
was introduced. And so I was like, hey, wait a minute. Maybe it's not that emotional vulnerability isn't the thing. It's just not the only thing. And at
Hmm.
that point, I was like so CBT ingrained that I hadn't really thought about the relational treatments, or I was like, psychodynamic treatments, that's baloney.
Yeah, totally. I have felt that way myself, and then the more I talk to people, I'm like, oh, maybe it's not actually baloney.
Yeah, right. Like, I
Because I think
mean,
when you're in school, you're taught like Freud, dream analysis, and you're like, okay, great, like that's not actually what psychodynamic means.
right. And it's super not that, right? It's like using the therapeutic relationship
Hmm.
to rewrite your scripts about what you can expect for other people. I mean, if you're a CBTer, it's essentially an exposure that
Yeah,
lasts for a year.
totally.
And so, I was getting these inputs. And when I left BU to start my faculty position at University of Kentucky, which is actually where I went to graduate school. So
Oh, cool.
my mentor retired and I took her tenure line, and I
Oh,
was like
wow.
sort of back to my roots. I was like, okay, we're going to do this. We're going to write a treatment for BPD. And, you know, I kind of knew at that point that I wanted it to be comprehensive and I wanted it
Hmm.
to be really mechanism focused and personalizable.
Yeah. Which it definitely is, and we'll get. I want to get into the personal. Wow, that's not the choose your own adventure. We're gonna go choose your own adventure because apparently it's too early in the morning for me to say the word
That's more fun
personalizable.
anyway.
Yeah, it is way more fun, and I loved that about it because I had some reflections of my own on how what I ended up needing to focus on. But so normally I ask this at the very beginning, but I'm super curious after hearing a bit of your trajectory. Why BPD?
Yeah, I mean, great question. So I think a couple of reasons. So when I took a year off between undergrad and graduate school because I, like many people, did not get in the first time,
Yeah.
and ended up working at a residential treatment center. And it was like for young adults. So it was people that were in the same life stage as me, and
Mm-hmm.
many of the people had borderline personality disorder, and it was really the first time that I had like knowingly interacted with people with BPD outside of like a textbook in my
Right.
my undergrad classes. And I remember just feeling like you are on a different sort of trajectory or path than me, and like like just being really like curious and compassionate about like how did that happen,
Right.
and also seeing like many things that we had in common. And I think like being around people that I felt like had so many attributes that were like me, but like also seeing places where people were struggling. I don't know, like I think a lot of times generalist clinicians, or depending on who you're around, right, who's training you, people are like, oh, like I don't treat BPD. But like I
Yeah.
had started my career in this place where I was interacting regularly, and it was residential and it was in like a house. So we were just like
Hmm. You were
hard,
like, yeah,
right?
exactly. Like actually interacting and realizing that like we're not actually horrible people 24 hours a day.
Right. That have much more in common than not,
Yes.
as like
Yeah,
both 22-year-olds.
totally. Yeah, that's I mean I think the residential thing is huge because one of the biggest issues that I think contributes to stigma is that most of the stigma comes from like they've done lots of research on like nurses specifically, and it's because you go to emergency room when you're at your worst and they never see you when you're not at your worst.
Right.
And so totally makes sense that you would have been like, "Oh, these are actually like regular humans that have some challenges obviously, but I can relate with them." Well, that's cool. Thanks for that
Yeah, of course.
that like history. So, you trained in DBT, wanted to do something different, and this, what was the other model you said?
Unified protocol. It's
Unified
a
protocol.
transdiagnostic, like, 16 session CBT protocol for neuroticism focused conditions.
Gotcha. So you kind of took all of these things and went, I'm gonna do something different. So how did you actually develop what came of this? And I want to dive into a bit of the evidence as well.
Yeah. So one of the things that I did, so I was at BU, I don't know, for 8 years. So I started as a postdoc and then was promoted to faculty. And at the same time, like Dave Barlow, is old. So he was like retired he was like half around. I mean, the man has retired like 6 times. So,
Yeah, of course.
you know,
Nobody like that retires once.
he was like kind of retiring. And so I was getting more responsibility. And at that time, we were revising the unified protocol for the second edition. So I got a lot of like behind the scenes on like how you actually write a treatment. Turns out it's like not that you open a Word document, you know, it's like not as intimidating as maybe it seemed, right? At the same time, too, I had also been put in charge of like the training arm of the unified protocol. So I was interacting with tons of clinicians. I was like going all over the country, providing workshops, and had ended up like when we decided we were going to revise it, made a survey and sent it out to everyone I had ever trained to be like, what's working, what's not working. So I kind of knew like how you put together a treatment. And you know, I think when I returned to UK, I was like, yeah, I mean, now I don't want to just do somebody else's treatment, somebody else's work. Like, I have ideas. I want to like, I think I can take all these things that I've collected along the way and turn it into something. And I think timing has not always been my strongest suit, because for some reason, summer of 2020 felt like the time that we were going to write this book.
Right. Good and bad. I mean, like summer 2020, you had a lot of time on your hands, probably.
Well, I had a 18-month-old and a 4-year-old. So
okay, no, okay.
But, you know, choices were made. And, you know, one of the things that, like, I don't know, I mean, hindsight is 2020, is that I had taken on practicum students. So I knew that I needed to be running a clinical trial come August, that we had to have a protocol, and that we needed to be able to train the therapists and recruit patients into the study. So, so there was like a time crunch. And so we wrote that thing, you know, I think between probably April and July. And we really split it up. So the authors are myself, Matt Southward, who is now an assistant professor at the Ohio State University, but was my postdoc at the time. My first graduate student, Julianne Wilner, who is now at McLean Hospital, she was my graduate student at BU. And Caitlin Hood, who was a graduate student at University of Kentucky at the time too. And so kind of split it up. Like Caitlin was really interested in substance use treatment and dissemination. And so she really took a stab at those impulsivity chapters. Matt had come from a training, like a very strong training in just like straight up cognitive therapy. So he had a lot to do with the cognitive work.
Yeah.
I did a lot with the values and the introductory and the personalization and the framing. And I mean, what came together was honestly like beyond my wildest dreams. That sounds so cheesy, but
no,
it's like really good.
It is. Yeah, it is really good. Yeah. I totally agree. I am. For those who listen to this podcast, they've heard this a million times. I have a really hard time reading. I'm not sure what it is. It's funny. I don't know if it's dyslexia. I'm not sure what it is, but I have a very hard time reading. And I often am asked to read books prior to podcast, whatever. And this one actually was really like meaningful for me to go through. And it was an easy read, which for me is a very like high bar. And so I think what you've done is made it really, really approachable, which I think is a huge component of it. So the clinical trial then, what were you comparing to treatment as usual? Or was this your 6 patients that you were saying you did kind of a case review or whatever on?
Yeah, so the 6 patients was when I was still at BU, and that was like straight the unified protocol, just autism treatment. So this was a waitlist control trial. So patients, it was a like immediate treatment, delayed treatment. So everybody ended up getting the treatment. Just some people had to wait 18 weeks to get it. And so that's an important piece too. The treatment is 18 weeks long. So it's a short-term alternative to these year-long twice weekly treatments. So not just DBT, but that's kind of the model for mentalization and transference focused psychotherapy too. And so we recruited people with BPD because I was coming from this sort of transdiagnostic, like nobody has just one disorder sort of lens. We really tried not to exclude very many people. Like if you also had bipolar disorder, you could be in the trial as long as you hadn't had a manic episode in a year. So like you were
Right.
that had been kind of handled via medication.
Otherwise, the impulsivity thing is just out the window. Like you really
Yeah,
can't test that.
and
Yeah.
a behavioral treatment isn't the right move for that. That's not the first line of defense, right? Like if you had been psychotic in the past year, if you, I mean, in terms of like handling suicidality, like we really only referred you out kind of if you like during the intake or the phone screen were like, I'm going to,
Yeah.
I'm going to engage in these behaviors like today, but then we'd be like, go to the hospital, but then come back and see us after.
Right. Yeah, totally.
Yeah.
And what's cool is like a lot of times BPD or any personality disorder is the exclusion criteria for new treatments. So
exactly.
So it's like I'm thrilled regardless. I'm like, this is
Yeah.
amazing. It's our turn. Let's get in there.
So
I
after
think
a year,
that's great.
we had recruited 50 people, and we were powered at that point, with like kind of trial design. We had enough people to be able to detect an effect on BPD symptoms, comparing people who got the treatment and people that didn't. Of course, it's a low bar, right? Like nothing compared to the treatment. But we stopped recruiting we paused recruitment at that point, and did these comparisons. And what we saw were large improvements in BPD symptoms from pre to post treatment that were, if you're in the science world, it was like an effect size of over 1, which translates to like a large effect, like a big deal.
Yeah, totally.
And really comparable to, meta-analytic estimates of like a year of DBT. So like,
right, in 18 months.
Like good effects.
Yeah.
And obviously like getting the treatment was significantly better than not getting the treatment. Yeah. And so once we knew that the treatment worked, we were like, well, we don't really need to randomize anymore, but we kept recruiting. So we recruited another 50 people. And then in that original study had 100 people that had gotten the treatment either immediately randomized after the 18-week wait or just like immediately, but not randomized. And that's where we've been able to look at more sort of nuanced things like what's driving change. We've been able to look at alliance and skill use and actual personality change, because that's what we're targeting, that neuroticism, antagonism, and disinhibition. And we see that those traits improve significantly across treatment, and that they predict improvements in BPD symptoms. So we're like targeting what we thought we were targeting.
That's fantastic. Do you plan on doing larger studies that is comparing directly treatment as usual or other modalities?
Yeah, so that'll be like the next step. So now we're doing a big study. We have funding from the National Institute of Mental Health to do a personalization study. So in the initial trial, because it was sort of proof of concept, like, is this a good treatment for BPD? Everybody got all of the modules. And so in the study that we're recruiting for this summer for the next 3 years, will be a personalized selection and order of modules depending on your elevations on these personality dimensions. So basically seeing like, if your BPD is driven by negative affectivity or neuroticism alone, and you just get, 10 weeks of that module, like, is that enough?
Yeah, totally.
Really just like hammer in on the thing.
Yeah. And people might be more willing to take part if it feels very relevant to them too, I would assume. Yeah. So the way that you have this laid out is really cool. So you just mentioned personalized approach, right? And so you talk in the book about having the 3 personality traits that put people at risk of development of BPD. So the negative emotions, the relationship difficulties, and impulsivity. And then you do a whole deep dive into all of those things, which is amazing. But then there's the way that you've done this choose your own adventure thing is by getting you to do in the workbook itself, like a bit of a test. Test is maybe the wrong word, but do you want to tell us a little bit about this assessment?
Yeah. So that's called the 5-factor borderline inventory. It's a measure that was developed by my friend Stephanie Sweet at the University of Oklahoma. And it is a way to, instead of measuring BPD symptoms by like, how severe are you on the 9 symptoms, it's asking questions about these different personality traits. So you're sort of getting a profile of the personality traits that kind of underlie some of the symptoms rather than the symptoms themselves. So it's sort of like a more mechanistic way of thinking about BPD, like what are the processes driving it versus like what does it look like on the surface?
Yeah, and I think what's nice about this is if you just ask somebody like, "Do you experience any of these 9 symptoms?" It's really easy to either just say yes to all of them because somebody we've all experienced most of them at some point,
Yeah.
or to be like, "Oh, I'm really not sure." Whereas
Mhm.
this is more detailed. So, like for example, I'm just gonna give like a couple examples of this. You go through and score yourself on a scale of 1 to 5 around like my anger has gotten me in trouble. Like that's pretty black and white. I feel like an outcast. I sometimes feel nothing is real. I can't trust my closest friends. Blah blah blah. So like it's much more. It's less like DSM symptom based, and more so about how you actually function and asking you about your real life, which I find really helpful. And then you go through and you assess, you score all these things. I'm really bad at math, so I had to use a calculator.
Mhm.
But then it kind of gives you an idea of which areas you should focus on. So, for example, for me, of the three things: the negative emotions, the relational difficulties, and the impulsivity. Mine were all relatively close, and I think that's just lots of years of treatment of being able to kind of navigate life pretty well. But the negative emotions one was definitely the highest, and so and particularly the anxiety domain, I got 100% score on that one. So I think it was cool for me even to go through and see, like, for example, it talks about anger, anxiety, and sadness, identity difficulties. And, like, I got a 6 on identity difficulties, but a 20 out of 20 on anxiety. So not that that's surprising, but it's nice to see it in like a little bit more of a black and white way of like some an assessment where I'm not just assuming that I don't have challenges with identity issues, but that like I can answer a bunch of questions that are indicating that I may or may not have these things, and then I can see an actual number. I don't know. I thought it was
Yeah.
cool.
I mean, and how much more like information is that than like you have BPD?
100%.
Right.
So much more
And
information. Yeah.
that's the idea.
Yeah, and then it goes on from there, the workbook goes on from there to actually create your own treatment plan by looking at those areas of the higher score, and then being able to tie those things to specific chapters of the book. So like for example, the ones that it told me that I should focus on is it's okay to feel, the avoiding, trust is not all or nothing, and getting vulnerable in a good way, and then urge surfing. But there was a few things where like celebrating small wins, I don't need to do that chapter because I do that all the time. That's really my bent. Like my whole thing is about like strengths based
Yeah.
celebrating wins. So to me, if I was going through and being like, oh my god, I have to go through every single chapter and like I have to do a chapter about something that I know I'm really good at, that would be more frustrating. But being able to kind of like decide as you go, and you could, of course, I'm sure there's benefit, like you said, of the you guys had gone through everything, sure there's tons of benefit in that, but it was nice to be able to kind of pare it down to things that I might have needed more than others.
Yeah. And when you think about celebrating small wins, right? Like focusing on what is the most crucial means
Mm-hmm.
you're going to get like early
Yes.
traction,
Yeah,
You don't have to wait for a long time to get something that feels relevant to you.
totally. So what do you find the most exciting about this book and modality?
Oh, that's a great question. I think when I was developing it, if you'd asked me, I would have said the ability to personalize it,
Mm-hmm.
and the fact that it's short term. But honestly, like my favorite part of the treatment is the values identification and the values pro part of the book. And I think has become my favorite just by virtue of having gone through those skills with actual people. We originally we included the values because we thought, oh, like this might be like good for identity. Like this is cool. Like let's do this. I like doing values work, in my sort of like general practice.
Mm-hmm.
But what I didn't really realize while we were writing it, but just sort of like kind of happened naturally, is that I don't I don't want to be in the business of telling my client what behaviors they should change, what's a good or bad behavior,
Yeah.
right? Like I want them to think about like how do they want to show up in their relationships,
Mm-hmm.
in their work, in their approach to health and wellness, in their citizenship, in their spirituality. And like then the question just becomes, well, does this behavior take you farther away or closer to your values? And It makes practicing skills more motivating, right? Because we have
Yeah.
something we're moving toward instead of just like stop doing that. And it is, oh, I forgot. I totally lost my train of thought. But
Well,
values.
I assume that it would also help with identity, like understanding who you are as a person, if you can understand what your values are. So I think
Yeah.
that could kind of cross that box off as well.
I think that that's true. I mean, it's really interesting. Like I love doing values with my like college student
Yeah.
clients. But really like anytime I've done values with people, they really haven't sat down and systematically thought through all these domains of life and
Mm,
figuring out like what you value, who you want to be is a big question. We try to like scaffold it like super hardcore. So
yeah.
we have the different domains. So say like parenting, for instance. And then we have this bank of words like a creativity, spontaneity, freedom, love, joy. And you go through and you pick the words that you feel like just kind of jump out to you. So it's sort of just
Hmm.
like, you know, what inspires you. And then you write some notes on why you picked each one of those words. And it's just like brain dump, just what are you thinking? And then we use that to kind of come up with a mission statement that is your value. So like for parenting, for me, I'd probably choose um love, spontaneity, and autonomy.
Mm,
And I'd probably pick love because I want my kids to just like really just like feel supported and
yeah.
connected to me. For spontaneity, this is more aspirational, but I want to be somebody who, when my kids are like, hey, look at this, and I'm like checking my email, that I can be like, yes, I'll look at this.
Yeah.
I can do it, that I don't have to be so rigid. And then for autonomy, like, I love my job. I love my life. I don't want to be like mom as my only role.
Yeah.
And so coming up with those, just those like little phrases helps me to think about, okay, so what's my value here? Well, I guess I strive to be fun and in the moment with my kids while also reserving time for myself.
Yeah.
And that, it just helps you get there. So we try to really scaffold it. And the coolest thing is during the trial, working with people, we would get to the behavior change module and, we'd be asking them to engage in behavioral experiments. And, they'd come back and they'd say, just like spontaneously, not prompted by us, oh, well, it was really hard, but it was in line with my values. So I did it anyway. Just like, oh my God.
Oh, that's amazing. Don't you love those small wins where you're like, or even, I mean, I don't even know if I would call that a small win, but like to see things being used in practice is so amazing.
Yeah, just the language being adopted. It's so cool.
So for those people listening who maybe can't get into treatment, whatever that treatment is, there's plenty of people listening that's a problem. Finances are tough, all that jazz. Do you recommend them picking up this book without a clinician supporting? Or is it really designed to be used in partnership with a clinician?
Yeah. So the book itself, when we wrote it for publication, it's very similar to the workbook that we used in our trial, which was led by was like weekly meeting with therapists. It's very similar to that workbook, but we did like really like thoughtfully go through and design it to be something that you could go through on your own.
Mm-hmm.
Another thing that I also tell people with it is that like, and we touched upon this at the beginning, like a lot of times BPD specialists have a long wait list or they don't take insurance, and so, another thing that we can recommend to people is like, if you get this book and you have like just like a generalist provider, CBT provider, you could take the book to them and be like, let's go through
Mm-hmm.
this together. I was actually speaking to a BPD advocate a couple days ago about the book, and she was like, man, like, the therapist that I had worked with for years, like she was game to work with me, but she was just like, I just don't have the expertise. And we
Yeah.
worked together for years and we got there. And I was also doing DBT skills group that she had recommended, but like this would have saved us so much time, and she would have been game to work through this with me. So I think that's another application of it. And I will say, like, the book, I think it's like $25 on Amazon US, but like, if that's a hardship for you, like, email me and don't tell my publisher, but I will send you a PDF.
Excellent. That is very kind of you, because yeah, I mean, I think the access issues are real, and you know, $25 might not be the end of the world to you or me, but for a lot of people that might be, right? And yeah, I really appreciate that. I also, you know, shout out to the publisher. I do really like that they add the worksheets online for free as well. I don't know if it's all of them. It seems like it is pretty much all of them.
It's pretty much all of them. And the ones that aren't are, I think, I have on my website.
Oh, okay.
There's
Gotcha.
a couple that are like embedded in the chapters, like not
Yeah.
the work forms. Those ones I think like are not up there currently, but like could be and should be. So that's some follow up with them on.
Yeah, totally. I like that because I'm like a markup person. Like I need to write things down, and then but once I write them down once, then I'm like, oh, I can't go back and write it down again. And so I really appreciated that you could, because you could just print out a couple sheets from the workbook, and then they have the it's not a diary card. I don't remember what you call it now, but essentially a diary card, the symptom tracker that's in here as well, that you can like kind of track your symptoms and your skills use over time. If I was a keener, I would you know, get a little duotang or a binder or something and print out all of those and then do it every week. And I can totally see the benefit, even just for me, having read many DBT books, more than I probably should, and having done a lot of therapy and things and working in the mental health system. It was a refreshing take, I'll say, that still really applied to BPD, obviously, and still felt, from my perspective, DBT informed, and CBT informed, which like obviously I kind of see that everywhere. So I'm probably overthinking it more than most people are. But because of that, I really just appreciated the simplicity, but the gentle challenge. You know, I think if I remember correctly, there's some point where you say like, you know, you might want to skip a chapter because it's too difficult, but like I really encourage you come back to it. And there were actually a few bits, I can't remember which ones now, but I can go back, where I was like, nope, I'm uncomfortable. Like, I'm uncomfortable with this. I don't want to do it. And then I was like, okay, Lori, well, that's a sign that you probably really need to do this one. You know what I mean? Like, I don't care how uncomfortable you are, but like, you should probably get there. It's not like they're asking you to do something like inappropriate, right? And so it was a helpful reflection tool for me. And again, like it's an easy read, which I very much appreciate.
Yeah, I mean that really means a lot to me, and I think like, you know, it sounds like for you there's enough like familiar that it felt like credible and you know,
totally
in the right direction, but some like new stuff too that felt like fresh and like would be a good challenge. And I mean that's exactly, I mean, I am a CBTer and a DBTer, so it makes sense that it would sort of smack of that and like bring in some of the other things that we know work as well.
Yeah, and we should do that, right? I think all modalities should be flexible and willing to bring in things that others, you know, have that are more beneficial. So yeah, I love to see it. Yeah, it's the kind of thing where I feel like because it doesn't talk about each symptom individually, except I guess impulsivity, it kind of does, but it feels less significant, like less big. In a sense, like I'm not trying, like hypothetically, I'm not trying to tackle the fact that I dissociate every day. I'm trying to like, you know, feel more or whatever, right? Yeah. Like it's like a bit more like layman's terms, I think, than maybe some books are, which is like incredibly needed. And especially if, you know, if you speak other languages and stuff, like you can't read Marsha's 1993 text. Like that's not going to happen, you know? So
I read it. I know. I teach a class on DBT every fall.
I know, I've read it too. It is a challenge, but that one, but like, you know, this kind of thing I feel like is really not, and could totally be used by clinicians. So is there anything we haven't talked about that you really wanted to talk about?
Let's see. So we've talked about the personalization part. We've talked about like use with generalist clinicians or self-guided. So we talked about access issues. I mean, we've talked about like targeting personality traits, I think the only other thing really to say about it is like the approach to skills. And so they're like after like, values and the assessment that kind of tells you what chapters to focus on, there's like the modules for negative affect or emotional vulnerability, for relational issues or trust, and for impulsivity. And within those modules, there are just 3 skills. I know that sounds crazy if you're a DBTer, but
Yeah.
it's thinking skills, doing skills, and being skills. So cognitive work, behavior change, and flexibility and mindfulness. And, we do that for a couple reasons. But really the main reason is that there's some research that suggests that getting really good at fewer skills is actually better for you than just like having a huge repertoire to choose from.
Right, because you never use them.
It's like
you get overwhelmed.
Kind of.
Yeah.
And it's repetitious on purpose. So if you need to do like, there are definitely nuances, right? So when you're doing thinking skills for negative emotions, it's like a CBT thought record. When you're doing thinking skills for relationships, we do this like dimensions of trust exercise where it's like specific to like black and white thinking about trust. Nuances to it, but it's like the same underlying principles. And it's that like the more you practice, and like you don't need a whole new skill for relationships than you do for your emotions, right? It's like apply the same skill, get really good at it. And I guess the only other thing to mention, kind of related to the skills, related to the personality dimensions, is that these treatment targets, negative emotions, relational difficulties, and impulsivity, they are transdiagnostic. And so, the average number of diagnoses that the people in our trial had was 3, right? Like, so people are not coming in with BPD only.
Yeah. I don't know anybody that has BPD only.
Yeah, right. No, totally. The most common comorbid condition was social anxiety. Oh, one thing. We did it like a daily diary study where we looked at the most frequent emotions experienced by people with BPD, and it was anxiety, not anger, as the diagnostic criteria would make you think. But it's anxiety. And so by targeting how you respond to your negative emotions, our clients see improvements in depression and anxiety and eating disorders, in substance use disorders. Same deal with like impulsivity and substance use disorders. And then for like trust, right? Like, I mean, again, like I'm sure this is like a frequent topic on your podcast, right? But like many people with BPD have experienced traumatic events, but not everybody, right? And it's not everybody. Most, right? Like probably half, or close to half. And targeting trust is important for everybody, but might be particularly important for people that have had those experiences.
Yeah, and you can also prioritize not only in the do them or don't do them, but like rank, right? Yes. So like if I'm entering a new relationship, for example, or a new job, and I know that I like need to really prioritize my interpersonal stuff, you can focus on that. Whereas with DBT, I mean, obviously with your initial like your one-on-one clinician, you could do that, but it's more so about like you start with mindfulness, then you do emotional regulation, then you do stress tolerance, right? So it feels more applicable to like your current state. And I wouldn't be surprised if like a year from now I go back into this book and realize that like the few chapters that I didn't do are actually now the ones that I really need to do, right? And again, that's why I really like the ability to print out pages, because I hate a messy page. So we're gonna do a giveaway of your book when this episode comes out, so I'm super excited about that. It comes out, as we mentioned, August 1st. Is Amazon the best place to buy it, or was there a different place?
Yeah, so Amazon is probably the easiest place to buy it. But on my website, I figured out how to like link to my uber local bookstore that is
amazing.
Yeah, so it's like a children's bookstore, but they also have like a very small adult section, and the daughter of the woman that owns it is like in my daughter's 2nd grade class, like uber
cute. Yeah. No, that's amazing. Well, yeah, I mean, we did that with another episode that just came out as well, around trying to like, obviously Amazon's the easiest. Sometimes if we're in Canada or other countries, it's the only option for certain things. But definitely trying to find it at your local bookstore first, obviously, is the best call. So I may send me the link of that uber local one, and I'll see if I can find a Canadian version that has the book. But of course, it's just coming out, just super recently. So, my final question is always, what do you like most about working with people with borderline personality disorder?
Yeah, that's a great question. And honestly, like, I think you'd be hard pressed to find a group of people that are trying so hard. I think like sometimes the trying gets misunderstood because it isn't effective, but like people are out there, they're trying so hard. They want so badly to like do right in relationships
Mm-hmm.
and move forward with their goals. And I think too, like when you work with people for like a little bit longer than the 12 sessions that you would to treat panic disorder, you just like are rooting for people so much. And I just like that.
Yeah, that's a brilliant answer. I don't know if I've heard that answer before, but it's so true, right? Like we're in so much emotional and often sometimes physical pain that we're trying so hard to get out of it, and like you said, sometimes that gets misconstrued, and it shouldn't. But it's humans. Humans will do that. They like to misconstrue and mind read.
Hard out there.
It is really hard out there. So where can everybody find you?
Yeah, so probably the most direct place to find me is at my website. So, and it's just my name, so shannonsauerzavala.com. Confusingly, I have a hyphenated last name, but there's no hyphen in the URL.
Okay. And I can put that on, I'll put that in the show notes as well. So
Yeah.
so you can find Shannon there. Other than that, you're on Instagram as well, right?
Instagram, yep. So
Yeah.
at self.made.personality. So the idea that you can self-make who you are.
Yeah.
And I'm on LinkedIn just under my name as well.
Amazing. Well, I'll link those as well. Thank you so much for everything that you're doing. And please thank the rest of your team as well, because I know that this kind of work is like, one person often speaks about it, but it's a team effort. And it's really incredible. And I really look forward to kind of seeing it continue to grow and be tested, maybe, larger scale studies, that kind of thing, so that we can really showcase that, like, as much as I personally am obsessed with DBT, that like we do need other options, and we do need this kind of innovation that you're doing here, because the minute we get stagnant, the minute we don't make progress.
Yeah. I feel like this is like the best I can do right now, but as a researcher and like a person, just like a curious person, like I think the goal is to keep improving and innovating.
Yeah, totally. Amazing. Well, thanks so much, Shannon. It's great to have you on.
Yeah, my pleasure. Thank you so much for having me, Lori.